Hello everybody and welcome back after a lovely long summer we've had off of our brunches. Now we're back and raring to go with Becky Thomas, who usually sits behind the scenes, but today she is the star of the show. So we're going to be talking about all of eyes because she is in fact the queen of eyes, and she has a crown and everything. I'll introduce everybody. My name's Amanda. I am a diabetes specialist nurse and I work in Medway in Kent. Beth?
I'm Beth Kelly. I'm a DSN, currently working in Southampton at the moment, but moving to Wiltshire in the next month or so.
Exciting times. Tamsin?
Hi, I'm Tamsin. I'm a diabetes specialist nurse at the Royal State University Hospital.
And Vicky?
And I'm Vicky and I'm a diabetes specialist nurse and I recently started as an Eden educator at Leicester Diabetes Centre.
Brilliant. And Becky, tell us a little bit about yourself.
Right, so I am a senior research officer down in Swansea University Medical School, and my main interest is retinopathy, although I have become the informatics lead, so I do any big data studies as well to do with diabetes down there. But before I did my PhD, before I joined Swansea, I was in Cardiff, but then before that, my life started in diabetes in the Welsh screening programme. So I was the senior retinal grader there when the programme first went national. So I was there right from the start. So most of my experience is based in Wales. I did do some time based with the Gloucester screening programme as well with Peter Scanlon, but a little bit of English knowledge as well. But it is quite different in England. So yes, so that is me.
You are very much go-to eye person. I think if we have you on speed dial.
Absolutely. So whilst people are joining on Facebook, we will ask you some random questions. We were trying to think of some questions about eyes, but then we couldn't really.
We've asked you them all before in our.
Yeah. So we're going to ask you a completely utter random question now, and this question in particular gives me palpitations, because it's, if you were only allowed to keep 3 apps on your phone, what would they be? And for me, I've got to keep my Libra. I've got to keep my son's Dexcom. That means I've only got 1 left, and I can't choose. There's too many. There's too many.
Have to be.
Just say what you're going to do with Twitter or WhatsApp. I mean,
WhatsApp? Is it Twitter? Is it Facebook? Oh, I don't know. So, Becky, what ones do you?
Oh, I would have to keep WhatsApp and I would have to keep Twitter, and then all the others would be a toss-up.
Yeah.
All my photos get uploaded to Facebook. I could probably do without Instagram. I'm not, I'm just looking at all my apps now to see which ones.
So scary, isn't it? I think like when we think about what apps we use to run the forum, 101, all that stuff, like we run everything with apps, we'd be screwed.
Yeah,
I don't think
it's got to be WhatsApp, hasn't it? Totally, there's just no argument. WhatsApp, definitely. I think Twitter, because, as you said, Beth, you can just like lose yourself in Twitter for like 20 minutes whilst you're waiting for something. It's just that third one, isn't it? Like, what do you keep as the third one?
Difficult.
Like, is it your bank details? Because you might want to, do something with your bank, or is it something more fun?
Yeah, I don't think I could cope without my banking app now.
I don't even know what my password is to get onto the website, never mind anything else.
You struggle.
What about you?
I think I'd probably have to keep my photos, although maybe I could upload them to a memory stick and then choose something else. But yeah, I think photos.
Where were we before smartphones? Okay, so I think we've got quite a few people joined now, so we'll get back down to business. Beth, what was the question that we were going to do as an opener? I think you had the perfect question that everybody's on.
I know personally, like we've asked Becky this loads, don't we? And it's something, I don't know why, but it's always one that DSNs are always thinking about, and we get asked by practice nurses and other healthcare professionals. So how quick is too quick to drop someone's HbA1c, and why is this probably like so relevant? Is it always related to eyes, or
okay, so this is the eternal
it's a long one.
Yes, no, nobody's done a study to say definitively this is right or wrong, or it only works if you've got retinopathy. So that's the start point. So if you haven't got retinopathy, it's not something that you need to be concerned about. But if there is retinopathy there and you've got a high HbA1c to start with, so we usually see it if somebody's got HbA1c over 10%. Sorry, I'm still old money, so I don't know what the millimoles.
Someone do a quick conversion there. What's 10%? I'm in new. I only know new money. What's 10% in old money into new money?
I'll Google it.
I want to say 75, but that might be 9%.
Someone, if anyone knows in the chat, if you're old school.
Yes. Well, the conversion of
75 is 9, I think.
Yeah, so it's only if the starting value is quite high, so above that 10%.
86. Sorry.
There we go. That we would see, you would tend to see. So if you're going from 10 to 8, you could have a problem. But if you're going from 8 to 6, it's not so much of an issue, I don't think. So we've seen it in studies we saw it in the DCCT. We've seen it in type 2 studies where you initiate the insulin. We've seen it in studies following bariatric surgery. Most recently, we saw it in Sustain 6, so that was semaglutide. That was the only GLP-1 that we've seen it. I know liraglutide had a slight possibility, but it wasn't significantly different. So it was only the SEMA study that showed anything. So in that study, they had a 2% reduction in the first 16 weeks. So it's a really short space of time.
So 22 millimoles.
There we go. Yes.
I know what 1 millimole is in 11, so
it was a 16-week window. So what we would say is you wouldn't want to reduce the HbA1c by 11 millimoles in less than 6 months.
Really, 11? If they've got background retinopathy.
If they've got, it's not so bad if you've got background, you might push them into pre-proliferative, but after about 12 months, they're going to go back to background. It's not, it's if they've got the pre-proliferative or the proliferative, and you're going to push them into needing laser treatment, that's where the issues then become, because it is.
Yeah.
What actually happens? What's the process? What's actually happening?
They don't know. The theory is, it's not been proven, but the theory is in retinopathy, because you've got everything leaking out of the vessels, the blood's not going through the vessels, so the eye is lacking oxygen. But in hyperglycemia, there's an increased blood flow going through the eye. So if you reduce the HbA1c, so you get rid of the hyperglycemia, you're reducing the blood flow, which is increasing the ischemia. And then that's when the eye goes, oh, I need to grow some new vessels to stop this process. And that's the theory behind it. It's not been proven, but it's.
And is this like different because it's obviously a GLP-1 therapy, which we wouldn't use in type 1. And the thought is people with type 2 are presenting usually with a higher risk of retinopathy anyway, because they've probably had hyperglycemia for longer. So it doesn't equate to type 1 diabetes as well. Is that right?
No, it would be the same in type 1 diabetes as well. Type 2, the DCCT was type 1 study. So if you reduce, anything that's going to drop the HbA1c quite quickly is going to be a problem. And actually retinopathy is more of an issue in type 1 than it is in type 2.
I was going to say, we do tend to see on Twitter people posting things about retinopathy in type 1. Are there any other causes for it other than that drop in HbA1c? Is it just having diabetes in general? Is that a risk factor?
It's diabetes that is going to cause you to get retinopathy. We don't see retinopathy in normal condition. People without diabetes might have the odd microaneurysm present. There are studies that have shown that, but the rest of the retinopathy is diabetes related. So the longer you've had diabetes for, the greater your risk of having retinopathy in general. So that's why in type 2, if you can delay somebody getting type 2 diabetes, keep them in the pre-diabetes stage for longer, it's more beneficial. But obviously you can't change when you're going to get type 1 diabetes. That's just yeah.
But keeping HbA1c levels at kind of an optimum target, is that sort of protective?
Yes, it is. And so both DCCT and the UK PDS studies, they both have shown that even a few years of HbA1c being in that target range, so being low. So DCCT was about 6 years long, I think it was. But then 18 years later, there's still a protective effect of that. Even though HbA1cs have risen again, that low HbA1c at the start is still protecting. 18 years later, there's less people getting retinopathy.
And is that what we term the legacy effect?
Yes.
And people talk about, having, diabetes for 20 years, and then after 20 years, the likelihood of you having complications from an eye point of view is higher. Where is that coming from? Things like, trials, or is that just a bit of a general myth about 20 years?
No, 20 years, not a myth. It's come from, there's been systematic reviews, there's been trials where they've seen it, but after about 20 to 25 years, approximately 90% of people with type 1 diabetes would have some form of retinopathy. So it is quite high, 90%, but that would be mainly background retinopathy. So for sight-threatening retinopathy, it would be lower. You're looking at about 20-25% after that 20 years would have sight-threatening retinopathy. So I know the number 90%, that is quite scary. And I've shown the graph several times to people and they're like, oh my God, it's inevitable. Everybody's going to lose their sight and things. But it's the background retinopathy that most people are getting.
It might be helpful if you could go through the kind of stages, and then, so where does background retinopathy fit in terms of life sight threatening? I mean, what are the stages that people go through? Okay,
so we've got R0, which is nothing, there's nothing in the eyes, everything looks normal. It's all great. Background retinopathy then would be your R1s. So
Becky's coming to us with a hotspot on her laptop, which is, sometimes cuts out. So we'll just wait for her to come back in. Hopefully she's not. We lost you a minute there, Becky.
We got to R1.
Sorry.
It's all right.
Yeah. We fight my hotspot and it's
you turned into a little bit of a Dalek. Exterminate.
Where did I get to? What did you hear?
R1.
Yeah. R1. So background retinopathy. So you're looking at anything from a small red spot. So microaneurysm, it's like if you were writing in a Word document, it's as small as like a full stop. It's a really small change. So it can be anything from a single one of those all the way to less than 8 hemorrhages. So less than 8, bleeds in the eye. So it's quite a wide category. You can get some exudates in there as well. So that is fatty material leaking out of the vessels. We could get some cotton wool spots. So they would be those ischemic patches. So they're where the eye is lacking in oxygen. So it's quite a wide category. So you don't, when you get your results that it says R1, you don't know where you are. in that. You could be right at the start, you could be, you know, close to tipping over. Then we've got the R2, so that's your pre-proliferative category. So that's anything with more than 8 hemorrhages, but you're also starting to get changes to the blood vessels themselves. So you can get venous beading. So that's where the vessels become sausage shaped. You know, if you see a link of sausages, so it's fat and then it goes thin and then fat and then thin. That's what's happening to the veins in the eye. So you get distortions there. So that would then be pre-proliferative. So your next one then is proliferative retinopathy. So that's when those ischemic patches have got so much that the eye has decided it's going to try and do something about it and resupply those areas with blood and oxygen, which, you know, you would think it was a really clever thing to do, but those vessels are really weak and friable and they will break. And that's then when you get bleeding out, and you get pre-retinal hemorrhaging, and it can, if it carries on, it'll go into vitreous hemorrhage. So the eye will literally fill with blood and you can't see through it. It's not until the proliferative stage that somebody would notice a change in their eyesight. So it's quite a late, and that's why we screen, basically, is to pick it up earlier so that we can treat before the bleeding starts. Is the goal, because that's the better stage, because otherwise the ophthalmologist has to wait for the blood to be reabsorbed by the eye before they can actually start lasering and treating those areas. In amongst all of those retinopathy levels, you've got the maculopathy. So that is probably the most common thing that causes so much fear, is this maculopathy. What in screening terms, what maculopathy is those exudates that I said that you could get in the background stages, if they occur within 1 disc diameter of the fovea. So the fovea is responsible for all of your central vision, all of your reading ability.
Oh, she's gone again.
That's that.
Oh, we got to abilities and then you cut out. Reading abilities. So what happened after that?
Oh, sorry.
Right.
Yeah, so fovea is responsible for all your fine detail, all your central vision, and your ability to read. So screeners are really protective over that small area. So if you get those exudates that you can get in background retinopathy, if they occur close to the fovea, that's their maculopathy. So that, you know, if they appear anywhere else, it's just going to be background retinopathy. But if they appear close to that fovea, we're now in maculopathy regions. So we'll refer you for that so that ophthalmology can do more tests, is basically what they're trying to do, because they can't treat maculopathy. What they can treat is macular edema. So the leaking of the exudates and the fatty material, that then leads to fluid buildup within the retina. Hang on, I'm going to sort my dog out.
He wants to say hi. He wants to come and say hi. Becky's got a new puppy.
Yeah,
well, he's not that new now, is he? He's a lockdown puppy.
Oh, he's a year old and he's very needy.
That's it.
So I think
yeah, so you get, so yeah, with macular edema, you get fluid buildup, so that then pushes the layers of the retina further apart, and that is what is affecting your vision. So ophthalmologists would treat that and not the exudates.
Interesting.
So the maculopathy can occur then at any point with background retinopathy, with pre-proliferative or with proliferative retinopathy. So it can come in at any stage.
So screening's really important. I think Tamsin had a question about screening, didn't you?
So, I mean, you probably can't answer for England, I don't imagine, in a sense of how things are working. But obviously, during COVID, screening for people that maybe had no concerns on previous screening got delayed quite significantly. But those that had obviously got retinopathy were still being screened. Is there a plan to extend the screening so that people aren't coming yearly? Is that something that, you know, you are aware of being discussed?
Yeah, so 2 years screening for those without any changes in the eye, so no retinopathy, that's been discussed for quite some time now. And actually in 2016, I think it was, the National Screening Committee for the UK actually said that we could go to 2 year screening. Unfortunately, none of the screening programs have been able to take that up at the minute. And I believe it's due to a IT software problem, and they're waiting for the software company to
IT problems in the NHS.
It's almost unheard of.
But I do think 2 year screening, I think it's going to come. It's needed because screening just can't cope with the numbers on an annual basis. And so unless they're going to throw more money at screening, you know, they have to work cleverer with the money that they actually have. And if you put those who are at the lowest risk out to 2 years, you can actually bring in those at higher risk in more frequently. Yeah. So that's what screening will, it doesn't want to lose the money that it has. It's about using the money, you know, more effectively. And so there are people who are under ophthalmology with pre-proliferative, so they're not being treated, they don't need treatment, but they need more frequent monitoring. We could get those back out into screening and screen them every 3 to 6 months. And, you know, that, you know, takes some of the workload off the ophthalmologist then. But that is sort of the plan for the future. I know Scotland have now changed their screening interval. So in Scotland, they've announced that anybody without retinopathy will go to 2 years. England, I believe, is planned for 2024-ish. But yeah, we have to wait and see what the IT works out as. There is another study that's going on in Liverpool that's looking at risk-based screening. So instead of just going off the retinal images, they would actually take into account your HbA1c, your blood pressure, and all those other factors that affect actually your risk of developing retinopathy. So it would make it a safer system, because even though we say people are low risk, so if you've got no retinopathy, your chances of going from 0 to a sight-threatening form in 3 years is really low. It's a low risk, but some people are going to go through that, and are we going to miss those? So is there a better way to pick it up? And we published a paper a couple of years ago now, and it actually said that if you've got type 1 diabetes, unless your HbA1c is like less than 6.5%, and your duration of diabetes is less than 12 years, I think it was, it's not actually cost effective to put you on a 2 year screening interval. The risk is too high. So there are some tweaks that may be needed, but at the same time, screening doesn't actually have access to that extra data. So it's...
Yeah, I was going to say, so will that be like a DSN job maybe to kind of risk stratify those people? And
I would imagine it will be part of ENIS or what system one, the GP surgeries, like how they call people for vaccinations, you know, that it'll probably be that sort of system, because that's big data, isn't it? You wouldn't be able to do that
at
DSN
they're
level.
referring anyway, aren't they? The GPs do the referral, so it's not the hospitals that do the referral. I mean,
trying to get a two-way conversation with the retinal team, as I know we've also spoken about before, Becky. It's crazy how they work opposite our office, for example, but we can't just send a patient over that we're worried about, like the amount of politics about it. And it's not them being, you know, not helpful. It's just that their system doesn't work with our system.
And I think every area seems to have a totally different way of running things, you know. So like personally, from, you know, having diabetes and being in different hospitals, in some hospitals you go to the hospital for the screening, but like now in Stoke, we have a screening team that go into GPs. So I go to a GP practice and they bring all the machinery to there, and I have the screening there, and then the pictures go to the hospital for review, and then I get a letter, and it happens really quickly. I get a letter usually within 10 days of having the screening. But then, you know, previously to that, I was going into opticians and having the screening done in opticians. So there just doesn't seem to be any kind of general consensus about how it works. It's like a postcode thing again, isn't it, for the NHS, that different areas do different things and run it in a different way.
Yeah, so in England, it's a bit different to Wales, because Wales, we just have the one national service and it's done exactly the same way everywhere. So we use GP surgeries, we use outpatient clinics, wherever basically they can get a screening venue. But England has something like 62 screening services, and that's come down from 90 something. So there's slightly less variation, but each service can do it slightly differently. So some do involve the optometrists, others, you know, it's completely in-house. Others then use a private company to do the grading, and, you know, it's outsourced that way. So it is a bit different in England.
Okay, thanks, Becky. So with screening still that we're talking about, have you got any information about what's happening? Because I know you did some work about the post-COVID catch-up, and you've got some infographics about that on the Diabetes 101 website. Can you enlighten us any more as to where things are at?
I don't know how well the catch-up is going. I do know that, you know, they are trying to get everybody in. They've got their priority system, but they have been affected by lack of clinic spaces. So certainly in Wales, we are down to about 30% clinic venues that we used to have. So people are having to travel further, you know, and we're just really struggling. Plus, with the cleaning that is required in between each patient, you know, the number of patients we can see in a day is less as well. So, you know, and then people are still scared to come out. You know, COVID is still around, so people are still scared to come to their eye screening as well. So it's a slow process. I think it's going to take a while for everybody to catch up, but the priority system is in place. So if you've got retinopathy, if you've got retinopathy, if you're newly diagnosed and never have had screening before, if you're pregnant, those are the categories that are on the priority list. So you should be being recalled soon. If you didn't have any retinopathy at your last screening, I know in England they are saying that it would be a maximum of 24 months before you would come in. So that's, I suppose, going towards that 2-year screening interval, but that's not going to be the policy at the moment. They do want to get back to annual screening, but yeah, it's slow, it's steady, lots of issues, but screening is ongoing. So please go to your screening.
All right, we've got some questions come in on Facebook. So I'll do the first one from Lynn O'Neill. So SGLT2s are showing cardio and renal protection. Is there any sign of this helping with retinopathy?
No.
Okay. Let's move on.
No, there's no evidence that it actually helps. You know, there's no beneficial effect on the retinopathy. Yeah, it's because it's
drugs as they are.
Yeah, but
they don't quite reach the eyes. They're
no, they lost the memo on that one. And then I think there's a question from Liz, and I think Tamsin was going to read that one.
Yeah, so with the increased use of GLP-1s now, and obviously we've got oral semaglutide now as well, is there any worry that we're going to see an increase in retinopathy? Is there any evidence that the Rybelsus causes any problems from the eye point of view like the injectable does?
The last I saw, there was no significant difference in the oral, so there was no issue. It didn't have the same issue as the injectable. So I think the oral one is fine. and it's just the injectable, the one that we have to be careful prescribing.
Alison Cox has said, I am seeing patients being screened, and when I ring to get a patient appointments, they're usually fairly quick, so it seems like the system's working. That's in London. What is confusing for patients is moving some to 2-year recall, which is not explained to them. So that's more about language matters type stuff, isn't it? We need to make sure that when we're telling people what we're doing, we tell them why.
Yeah, I mean, yeah, if the screening programs in England and Wales do actually go to 2-year screening, they will need to do a big patient communication thing around it and why it's safe and why we're trying to do it. But
because we've spent years telling them how important it is to go every year, and you must go every year, and now we're going, no, actually, you can go 2 years. It's all right. Fine.
Yes.
Yeah.
Do you think, Becky, it's confusing for some people? Because obviously when you go to the opticians and you have your normal prescription eye test and they do the retinal photographs, obviously I know they don't use the eye drops at that point, but that, you know, the person with diabetes sees that picture of the back of the eye. So do you think that then people think they don't need to go for their diabetes retinal screening because it's already been done?
Yeah, there is some people with that kind of thinking. Oh, I've had it done in my opticians. You know, I'm all good. They said I'm all good. It's fine. But the issue is if they don't use the drops, then the image can be quite difficult to see if there are any changes, because we are talking about small. You know, the microaneurysms are very small. So if you don't have a clear enough picture, then you could miss something. Plus the opticians are not trained to grade retinopathy, and so yes, they are great at everything that they do and they would have some knowledge, but grading is a specific skill set, and you need to be trained to do it properly, and you need to be seeing enough people to maintain that skill as well. So I think at the start of screening, we said that you need to see at least sort of 10,000 people with diabetes every year to maintain your grading skill set. So every optician isn't seeing that many. So
no, that's a lot. I didn't think that would be that much. Wow.
I think that's the age-old thing about when they see the practice nurse and they see the specialist, and it's like, well, I've seen this one, why do I have to see this one? I'm going to be two different things.
Aren't you all the same?
Absolutely, bless them. I mean, talking about patient communication, I know that that's a bit of a bugbear of yours and probably ours and patients too, that the letters and things that they get are quite scary and often put the fear of God into them. And I think maybe as well, DSNs, I'll admit, like I look at the letters sometimes and think, and I have to look it up what the letters and stuff mean, because I think retinopathy is something that we know and understand about, but we're not, because it's another sort of specialist outside of our sort of day job. It's something that we're not great at maybe explaining to patients. So are you doing some work or looking into maybe the letters? I know you've spoken to them a lot, haven't you, about the letters?
Yeah, the letters are a big bugbear. I mean, it is difficult for them to get the balance right, because some people want to know everything and other people just want to know, am I going to go blind? Has anything changed? And they really don't want to know anything else. So getting that balance in a population screening program is difficult. But the letters do need to be looked at. I know in Wales they did do a big study to try and change the letters. They got quite a few patients involved in what the language should be and everything. I think those letters have now been changed. I'm not 100% sure. I think they were due to change in March.
So if you're in Wales, let us know.
What
your letters looking like.
Yes, let us know if there's any
difference.
difference.
Do they reference Becky?
I wasn't involved in that one, but yeah, I know some of the programs in England have changed them, some haven't, and there's IT issues there as well with the letters because they're auto-generated, and it's difficult to get a new template on the system and things like that. So they do need to change. It does need to be some work, and the missing link for me is you get a letter, but as you say, you guys can't explain the letters to them properly, and there's nobody else. So the missing link is a person to go to, say, what does this actually mean? And it's easier to tell somebody what it means if you've got the image as well. Yeah. So I don't know whether, you know, some IT link system needs to be there so that whoever does the explanation has the image and can go through it properly with them.
Yeah.
It would be great if there was, you know, communication between screening and GPs, or, you know.
Or just like a brief, you know, this is what this means, this is what this means. I mean, we've probably got some stuff like that on the 101 website.
Yeah.
You've done some fantastic infographics for us. So
I've put the link to that in the chat on Facebook so people can access those.
There's another question from Alison. I think we kind of covered this earlier, but she's just saying that, just to confirm, the semaglutide with existing retinopathy, is it just the improvement in HbA1c, or is there something else in the drug that's causing that issue?
No, they have looked into that, and it is just this rapid reduction happening so quickly that's causing the issues. I mean, if you've got somebody in front of you and you think that semaglutide would help them, would be beneficial, I would say the first thing to do is to check that they've had a recent screening and what that result was. If they haven't had screening, try and get them into screening before you prescribe it, so you know what's going on. If they are under an ophthalmologist, if you could talk to them and tell them that you're about to prescribe this drug that could do something, can you see them more frequently? That would be, you know, great. I wouldn't say not to prescribe it, but just be careful. And if there's a way of, I don't know, is it titratable?
Yeah, I mean, there are other GLP-1s out there now that have higher doses. So like Trulicity goes up to 3 milligrams and 4.5 milligrams, and that you're seeing sort of a similar weight reduction. I mean, semaglutide is still higher weight reduction, but it's not far off. So there could be that route that you go down instead if you're really worried about somebody's retinopathy and you don't want to chance it and you can't get hold of anyone, you can't do it, you know, you could just use the other one.
Wasn't the thing with the SUSTAIN trials though is that they included people with, and that's where the date, like being very what's the word, analytical about data, which is where Becky comes in. We just learned from her, but they included people with that, was it proliferative retinopathy in their design, didn't they? Whereas
they did.
Rewind, I don't think do. So that's where they got this big result that scared everybody to death.
Yeah. So most trials would exclude somebody if they've got proliferative retinopathy, or, you know, if they've had treatment for it. So most of the other trials did exclude those people. SUSTAIN 6 didn't, and most of the people with issues already had treatment, and the proliferative retinopathy had stabilized, and so it's reactivated it, for want of a better word.
Difficult, isn't it?
So even if it really is, so even if you've got somebody who has had laser treatment, is now stable, then they're okay, I would be careful in those group of people as well, because you could restart it again. My main bugbear with trials is they don't look at retinopathy properly. So even SUSTAIN 6, they did retinal photographs at the start of the study and then just relied on serious adverse events reporting for the end outcome. So if you're not looking for it properly, so they don't know whether there was anything going on, were people going from background to pre-proliferative, were people, they have no idea. They only know that if somebody turned up as an ophthalmologist,
Yeah, and I assume that they were following their drug increase protocol very stringently, in a sense that they were going 0.25, 0.5, 1 milligram, basically, because it was a trial. Whereas in real life, if you know that person's got retinopathy, and Ozempic, semaglutide is your option of choice, because you don't necessarily have all the other GLP-1s on your prescribing, then you can say to that person, we'll keep you on 0.25 for much longer, and we won't you know, we won't make, you know, the changes to your blood sugar. So actually in real life you have much more control, don't you, than you necessarily do in a trial where they're being sort of pushed through the process basically. So you know, we use Ozempic, but like you said, Becky, we're very careful, and we do refer them to screening, and we are very in close contact with the eye team in the hospital, and we will send them to the eye team first before, and ask for their report before we would consider starting it. So that's, it's a difference between trial data and real life data, isn't it, in a sense that you might get those things in trials, but they're very rigidly going through a randomized controlled trial, aren't they? So
yeah. There is another study that's going to come out looking at this, semaglutide and the effects on retinopathy, but I don't think it's due to report until something like 2025-ish. So it'll be a little while till we see those results, but at least somebody is actually properly looking at it now.
Yeah, I find that crazy that like they make such a big deal about MACE now, like, you know, cardiovascular events and things now, don't they? And then so everything has to be checked against, you know, 3-point cardiovascular events, don't they? And then why aren't they looking so closely at retinopathy? Yeah, maybe that will change.
I mean, I think Sustain 6 did make people wake up to this issue again, because I think it'd gone quiet and people had forgotten about this early worsening phenomenon.
Yeah.
And I think Sustain 6 made everybody go, oh, actually,
yeah,
it might be something that we need to keep in mind and to think about. I think it reawakened everybody to the issue.
Yeah, I think, yeah, again though, it just created a bit of a postcode lottery with it, maybe, because like our area, so the area next door to us made everyone have, you know, they wouldn't give it to anyone with this, like as you said, pre-proliferative retinopathy, but you know, they made everyone get screening and stuff, whereas our place just said, yeah, just be careful, just you can go for it basically. So some places didn't want to use it, did they? I know Dorset, I don't think, had it on formulary for a long time. So yeah, it just opens up more postcode lottery places with this kind of stuff.
Yeah, in our area it's still specialist initiation only on formulary, so the practice teams aren't prescribing it at the moment.
Ours is like that for all GLP-1s.
Really? Oh no, we're allowed Trulicity. No. So I've just put in the chat if there's any more questions, and no one's asked any more questions. They're saying thank you, so I think we've probably come to a natural finish there. Unless anyone has a last minute burning question for Becky before we go.
Someone asked if you wanted to do any specific courses in retinopathy, like as a DSN maybe, but is there anything you know of that you can maybe do, or without having to do a whole new career change?
So I think so there was a thing there was a City and Guilds diploma or something at one point. I know it's moved to something else. I can't remember offhand what it is, but I think either UCL or Moorfields have launched a series of short courses. So it might be worth looking at those if it was something that you wanted to look at more.
Yeah, if you,
as well, I know it's covered in like the MSCs and all that kind of stuff, which is all on our website as well. People can look up and have a read about, but yeah, just a shorter course might be someone.
Yeah, if you send it over to, we'll put that on the website as well. Then under eyes,
yeah, we'll get googling
the eye page, Vicky.
Yes, okay.
Cool, right, thank you very much for giving up your Saturday morning. That was really informative. I think we've had a really good update there. So without further ado, I think we'll all say goodbye. Thanks for watching, guys.
Bye.
You can catch up on YouTube if you missed the rest. We'll put it all up on YouTube, and it'll be available on Facebook for a million
days or something.
Bye.